Thanks very much for those really informative and interesting presentations. My question or two is to you, Hazel. Sorry, because you're the data person. First one is, how does the global vaccines database differ from VigiAccess and VigiBase that the WHO provides, which is a global repository of adverse drug reports for both medicines and vaccines? That's the first question.
I go?
Yeah.
So with our reporting systems that come in, like we have in Victoria with SafeVic, where people are making in their adverse event reports, they should all then be going through into their national regulator. For example, in Australia, they come through to the TGA as a repository. They will also go through to the global WHO and into VigiBase. So it is looking around adverse event reporting. What we're doing with the GVDN and the Global Vaccine Data Network is tapping into other resources of data. So perhaps hospital administration data sets. In Australia, it's the Victoria, well, in Victoria, it's those hospital administration data sets. They have great long names, but, you know, coded admission data, looking at emergency department presentations, and aspirationally also looking at general practitioner data. So it's removing the bias of the need to actually be able to report and being able to look at the data in different levels of healthcare and pull that together.
Yeah. How do we get access to that? Or do you have to be a contributor to that database to be a member?
Also, the participating sites around the globe are the ones who are contributing in. But if you go through the QR code that I showed up there on the website, they are showing, so there's the data for background rates. So that's these conditions occurring without vaccine. There's also the data is now shown for the observed and expected. It's split by dose, by brand. You can look at the country level, etc. So as much as we have the permission to be able to share, occasionally we can't, because if it's very small numbers, there is also that personal potential that you could, you know, re-identify. But yeah, it's all there on the website.
Okay. My second question, very quickly, is using the words of another Donald, but Donald Rumsfeld, in the unknown unknowns. So with new vaccines, how are we going to pick up the unknown unknowns? Because TTS was a great example of that. It wasn't on our 20 preferred conditions that we were looking for. And there's lots of reasons how and why we picked it up. But as an epidemiologist, how are we going to find the unknown unknowns?
That could be a topic all of itself, but I'll try and do that one really quickly. I mean, myocarditis wasn't on our radar either, actually. I'm coming in for the mRNA vaccine specifically. Yours, okay, but not, you know, one. So really, this is around the swarm of data that we now have access to. I think there's two particular ways we find the unknown unknowns. One is astute clinicians who see something unusual. The earlier people speak up, and if we have our networks established where we talk together, you know, people know what's expected and what's not. So early mention means that we can dive in and go and look and inquire. The second one is around having access to lots of data and the systems in place where we already know our data, who it informs on and what it can inform on, and we can run statistical algorithms that look for things that are unexpected. The caveat to that is that you can't do it on the fly. You really need to know and understand data ahead of time. And this is the groundwork we need to be doing now, ready for the next pandemic, so that we can be quicker than we were with COVID.
To either of the other speakers, being human is a risk factor for getting an infectious disease that a vaccine can prevent. Having high blood pressure is a risk factor for stroke. Having high cholesterol is a risk factor for many things. Having low bone mineral density is a risk factor. There are many other risk factor conditions where we quite happily use medications, and yet I've never seen on the front page of the Herald Sun, 40-year-old man dies of liver failure because of a statin, or 60-year-old woman dies of a fall because of the low sodium induced by her antihypertensive diuretic. That's never on the front page of the newspapers. It's never in social media, and yet it's probably, in terms of absolute numbers of deaths, far, far higher. So why are we so worried about dying from or getting a serious illness from a vaccine when we seem to ignore it from many other drugs that we administer with almost impunity?
Oh, that's a good question. It's a deep question. We can get very deep. Look, there's probably a number of answers that one could give to this. One angle that I would take is it's our kids. It's people making decisions about very young babies. People have a different mental calculus when they're deciding risks for themselves as opposed to risks for their children. And so we know that with vaccination, sometimes people become paralyzed and they would rather do nothing than to take an action that could possibly cause harm. And I think that makes the decision around the preventative medicine a lot more fraught. I take your point that there are other preventative medicines that children may be taking, but we're not administering them to the entire population. And so you're also dealing with a huge number of people who have not been told that they have any sort of elevated risk for a particular condition. This is just a healthy baby that needs to take some sort of invasive intervention into them. So I think it's not logical necessarily, but humans are nothing if not illogical. You want to add anything?
Thanks.
This question, I guess, is for Cassia, but I think Hazel may want to comment on it. Hazel showed us the COVID cal, I think, that breaks down the risk of COVID and adverse events and risk after a vaccination. And clearly these risks vary with our dose, but also with how many times we've been infected, those risks are. Is that something that you think Sky can continue to incorporate in your information? Because I guess we know now that in Australia, for adolescents, say, 90% have had an infection, so their risk of getting hospitalised with COVID will be X, but also their risk of myocarditis if they've had 2 or 3 vaccines will be Y. And I think we need to sort of be able to keep people informed of exactly what your true risks are at any point in time. And I think it's a real challenge because it is changing, and I think it's because it can also work the other way, not just about people not getting vaccinated, but actually us not recommending vaccination. Because we say, well, actually, COVID's no longer a problem for anyone who's an adolescent. And you tell a mother whose child's got, a multi-system inflammatory syndrome and dilated coronary arteries, she may take point to that. So I don't know if you've got any comments about that, Cassia, about how we keep up to date with these sorts of things.
Thank you. Yeah, great question. So Sky is more of a communication guide. So how to have a conversation, how to elicit questions, how to share knowledge, how to listen. And I also showed a slide on NCER's, frequently asked questions and other resources which are continuously updated. So these types of information about clinical updates would be found there. And I would say, it's best as a provider to continuously update your, attend webinars. This landscape is so complex. That's all I could say.
So I'm going to steal it on the way through. Just also to say there's 2 decision aids that have been developed that are on the NCER's website for COVID vaccination for adolescents and for adults. And I know that the adolescent one in particular has just been going through this really enormous update because of everything that you've said. But it takes such a long time to do the update. So what we're really suffering from, and I don't know how the COVID Cal tool works, and maybe you can give us some sort of insights, but compiling that data regularly, getting it checked by the experts, getting it into those sort of key formulas and things like that, you're sort of out of date by the time you put it up. And so there's sort of risks associated, I guess, even with having that kind of tool. But look, if those kinds of tools are useful, if anyone uses those, if you like those, make that known, because one of the major barriers that Kasia mentioned is lack of funding. So if there is a particular instrument that you find indispensable in your practice and you would really like to see it really regularly updated, speak to the people who are developing it and speak to people who might be able to put some funding towards it, because it's mostly a manpower issue.
I did have a comment. I think it's just the real evidence that we need to work as a team when we work in the immunisation space. So you know, I'm sitting, you mentioned about not being clinical. I'm not clinical, but I'm an epidemiologist. So I deal with data. So my job is to get the good information. But in terms of being able to communicate that in a really useful way, you know, this is where I think it's really important about how should it be presented? How should it be communicated into communities? And then coming back again and saying, well, what is the questions that's right there burning, and having us as epidemiologists and clinicians, et cetera, working together to get the answers. It's this continual backwards and flow, and that we mustn't work in silos. That's my biggest thing.
Hi, just a quick one for Kazia. I recommend Sky at every opportunity. It's on the bottom of my email signature. I feel like asking people for their certificates before they order vaccines. But I was wondering if there was any possibility of publishing the numbers of when you log into the learning package, which professions are completing the learning package. I'd really like to know that, and I think that it would be really useful for that to be published. So not really a question, more of a, could you maybe please? We'd love to see that.
Thank you. Of course. And I think, Carol, you also have been involved in tailoring immunization programs, studies. Absolutely. This information is very useful, and we'll consider publishing it.
Hello, I'm Elisa. I'm a nurse with these SIP school immunisation people. I just wanted to say to Hazel, back in the olden days when we had an immunisation handbook, there used to be this fold out bit that had the risks of having a vaccination and the risks of having a disease. And what you were saying about the COVID vaccine and having COVID or having the vaccine, that would be a really good thing. I still think we should have that sheet because people don't know the risks of disease and the risk of a vaccination, because there's risks with everything. But it's nice to be able to show them so they can choose.
Is there anybody among here who'd like to answer as to, I think maybe you have the audience here who will hear that was useful in the handbook. No, that's right.
Oh, I was just going to say, I think that's a great idea, but you run into even more of the problem that we were just mentioning of as soon as you print it, it's out of date. And so then that's actually one of the big challenges, because, you know, misinformation can just be old information. And so that's probably the biggest challenge that we come to when we want to help people with, you know, in-person resources, especially around COVID, they're just so quickly outdated.
I just think maybe to add on to that, I was really excited to be able to present some recent data to you here today. But then thinking about that, it's nice that it's fresh because it was just like published last month. But these were the questions that were being asked like 2 years ago. So it is part of the scientific process, and it just takes time, and we need to go better. So it's available when you actually want it.
Hi, I'm Kalpana from Debro, a GP on the ground. Question for Sarah is that at 6 weeks, when the parents are very young and very concerned about the babies, first baby, you are already giving so many vaccinations. So one more meningococcal. What's your experience, and what are the extra added things that you need to tell apart from the fever and, you know, the local site pain and all of that?
Thought I'd escape being asked since I was the moderator. I think all of us are very busy at the 6-week immunisation visit. There's the child health check itself, checking mum to see how she's coping on top of the baby's first immunisations where they're often very worried. So I do the before, during, after. So I'm already preparing for this visit well in advance during their late pregnancy, and signposting that these are the vaccines that I'm recommending for your child. This is what the plan and the timescale will be. I see a diverse range of people from South America, China, Indonesia, where BCG is also on the radar, travel vaccinations, even things like rabies, Japanese encephalitis. There's nothing that's off topic. So it's 6 weeks, just to give you an idea, we have the routine childhood immunisations that are funded on the NIP, things like your the 6-in-1 Infanrix Hexa or Vaxelis. There's the rotavirus vaccine, as well as things like the 13-valent Prevnar conjugated vaccine. In Queensland, we've just recently had meningococcal B, Bexsero, funded on the schedule, and a catch-up for up to the age of 2, as well as our teenage population. But I'm also recommending private meningococcal ACWI as an option.
Yeah, that's
So-
what people are asking about.
That's right. So
Yeah.
there's the oral, 2 jabs on the NIP, and then 2 potentially the meningococcal vaccines. Depending on the patient, and Beyfortus as well, RSV on top of all of that. So very busy. Some parents, you gauge and sort of say, look, some of them have already had a chat and thought about it. Second, third child, they're like, can I just do everything in this one visit? They don't want to come back. And they've already had that experience with the first child. So I find the second and third child is parented very different from their very first one. Firstborn parents often very anxious, worried. Sometimes they'd rather, come back for another trip and separate things and come back separately for the meningococcal. And we warn them, and we've got written fact sheets that we say, look, there is at least a very good chance, maybe even 1 in 4, that we expect a fever. And that's why we do the paracetamol before, 6 hours afterwards, and another one after. It's going to last maybe for 24, 36 hours. That's when it's going to be the worst. But don't hesitate to come back or take them to emergency. It's okay. You're not going to be told off. So you find out what they would prefer. If they don't mind another visit, I don't mind another visit. It's another touch point. If they've got low weight gain, they're not feeding very well, sometimes I will deliberately space it out so they are made to come back as well to see me, because I can't do that as a telehealth. They have to come face to face.
Okay.
So you'll know your patients best.
Yes,
Mm.
so suppose they're wanting to have it, but they want to know what are the differences if they don't have it, and what if they do have it.
Hmm.
So how will the child behave, and what sort of things that are extra added for them to look after
Yes.
once they're having that vaccine at 6 weeks?
I love using the AusVac safety data sheets for that, because the percentage is like 89% of the respondents at the 6-week or 2-month visit. The parents responded and said their child really behaved no differently. It's like it was a non-event. And of the ones that did, respond, when we look at the breakdown, the fever, if that's their concern, that might have been 2% of the overall vaccinees. So I address based on using the data sheets, giving them previous experiences. Have they had other ones that have been poorly, reacted poorly, or if they had hurt, friends and families that they're worried about? So drilling down to their concerns and addressing it and finding out where that's coming from.
Yes, and like there is there are some studies showing that it is better to give them all together. Are they?
I find that it really depends on the practicalities. Most parents who've had a few children find that by the time they're older, it's harder to give them. The children remember. So by the time the second and the third, they're like, yes, we'll do all the rabies as
Thank you.
early as possible. We'll do all the vaccines that you recommend as early as possible, because they find that
Thanks,
the
Sarah.
child's a lot smaller. They don't remember, and it's easier for their parents. Co-administration, we know that the side effects are not cumulative. They are as reactogenic as the most reactogenic vaccine will be. So it's not like it's additive. So again, it's an informed consent and probably depends on the parents. And it varies so much even within the same parents. It's different from the first child to the second.
Thank you so much.
Even 2-month and 4-month and 6-month visits are different as well. And I'm sure that's probably what the audience has experienced as well. Another question?
Thanks everyone for your presentations. They were great. My name's Beck Doyle and I'm nurse researcher at Queensland Children's Hospital. And I'm glad you mentioned AusVac safety, Sarah. My question, I guess, is to Kasia and Jess. Do you think it's worthwhile creating some resources to give to parents, especially to say that we are watching, we are monitoring? We use AusVac safety a lot because it's so visual and easy to show them that, this many children have had a vaccine and only this many have sought medical attention. And all our kids at Queensland Children's who get a vaccination will get a Vax Tracker survey that they can also respond, that then feeds into AusVac safety. And I think often in those conversations, they seem to be happy that we're watching and that it's transparent and that they can see those results.
I know that Dave Durheim will be really happy to hear that that's being used. I'm actually working on a study with him, looking basically trying to get some data on what you're saying. So and I know that Hazel's been working on this. So everybody's actually trying to get data about this. Does the fact that we are doing active surveillance make people feel better? are people aware that we're doing active surveillance, and do they know about the AusVac safety website themselves, or how have they seen it? So there's multiple people looking into that. The problem is we don't have really good data because it's a little bit hard. You don't want to tack it on to the end of the survey that they're already getting, the Vax Tracker survey, because they've already just done it. They've gotten the vaccine. So we're working on designing some studies around that. I think one of the best uses of the AusVac safety website is exactly as you said, using it in the context of a clinic appointment where someone is expressing some concern around that. I'm not positive whether the fact that it exists makes a difference for everybody, but I would definitely encourage you to use it if you have somebody in front of you who's saying, I want to know more about it. I want to know what the actual level of risk is.
I think it's a great idea.
Yeah.
There was a presentation in the CDIC conference yesterday, Katie Atwell, and she was talking about the need to be able to express to our communities how hard we look, that's an important part of it, that we do look hard. Again, I think I totally agree with you in that, how do we then measure? Because we say, we do safety surveillance to help improve the confidence in vaccines, but how do we measure that it does actually change the confidence in vaccines? Probably changes it maybe for the immunisers and perhaps amongst the healthcare workers, but I'd like to get the message broader. So if you could just work that out, please.